So we are now 3 minutes after the hour, Josh. So I'm going to make the call that we can get started because I want to make sure that we have time for the seminar as well as for any questions and discussions. We certainly can take questions in the Q&A. So please, everyone, put your questions and thoughts there. And or the chat. The first slide I'll get started with first, which is, I have the luck, I guess, and the pleasure to give the logistics of what's going on. So this presentation is going to be recorded, and it's mostly for transcription processes purposes only, but we will be hopefully using these in the future for made available for review. So I'm excited about that. We've done this in the past, and it's been great because those who maybe can't make the meeting today will be able to see it in at another time. The people, including Dr. Gong here, that we have on the lineup are experts in the field, and so it's always interesting to hear what they have to say. The other thing that I find anyway is when I listen to these more than once, I actually get something else out of them. So the second time and the third time. So I appreciate that availability. We're going to ask all the panelists to keep your mics muted just so that we stay focused and not distracted. That would be great. And the Q&A and chat will be monitored for questions. So even if you're not a panelist, you still can ask questions if you put something in the Q&A. And with that, the next slide is actually just for me to say that this would not be happening if it weren't for the incredible help of our hosts, Dr. Jay Rappaport and Dr. Josh Fessel. And as I mentioned, the group led by these two have been talking about this for PASC for quite some time. We recognized it as part of the preclinical working group within ACTIVE. And because we've been so focused on the acute effects and acute responses to COVID, we've not had really the time to focus on this, but we do now. And really, because of Josh and Jay and because of the preclinical group, we've really focused on what can we do to help the preclinical space within this area. And so, and you're going to hear that throughout this series, we're going to be talking about everything from humans to clinical to the preclinical space in animals, because you can't divorce the two. So we really need to get a good picture of what's going on, and that's where that is. So I cannot thank Josh and Jay enough. They've been terrific. Actually, they've been terrific in this process, but they've been just terrific throughout the entire 18 months that we've been working together. And so it's been a pleasure. With that, I think I'm going to hand it over to Dr. Fessel to do the introductions of our speaker today. Josh?
Yes, thank you so much, Joe. That was very kind. The pleasure's been all mine in both working with you and Jay and the rest of the preclinical and the other groups in ACTIVE, and it's an even greater pleasure to introduce Dr. Michelle Gong as our first speaker in the seminar series in turning our attentions to PASC, or long COVID. I could probably spend an entire hour telling you about Dr. Gong's accomplishments and how incredible she is, but I'll try to keep it focused because I want her to have all the time available to talk to us. So Dr. Gong is a professor of medicine and a professor of epidemiology and population health at Albert Einstein College of Medicine and at Montefiore. Some people run one division, she runs two. She's the chief of the Division of Critical Care Medicine, as well as the chief of the Pulmonary Medicine Division. And she's also the director of the Department of Medicine's critical care research efforts. Dr. Gong has been a thought leader and field driver in the realm of critical care research for quite some time, going back well before the beginning of the SARS-CoV-2 pandemic. Much of what we know about how to better take care of critically ill patients, particularly critically ill patients with acute respiratory distress syndrome, has been directly driven by the efforts that Michelle and groups that she has worked with have undertaken. Dr. Gong participates in a variety of different research efforts across multiple institutions and multiple networks, including the PEDAL network, which is one of the largest critical care research networks that's supported by NIH and has been a key participant, not only in ARDS research going back before the pandemic, but definitely a key partner in acute COVID-related research. And so in addition to all of this, Dr. Gong is a busy clinician herself. We were just talking before we got started that the units are moving in her hospital today. And so I suspect that will end up taking up a fair bit of thought and time. So we are extraordinarily lucky and privileged to have you for a little bit of time this morning. To really kick us off in thinking about where do we want to go with our investigations, particularly thinking about preclinical long COVID or preclinical models of PASC. To do that, we need to know sort of what the lay of the land is, what problems we're trying to solve ultimately. And so I can't think of anyone better to help shape our thinking about that. And thank you so much for being here. The floor is yours.
Thank you so much for that generous introduction. So let me actually set up my screen and then to make sure you guys see. You see my slides okay?
That looks perfect on my end.
Terrific. All right. So thank you again for that generous introduction and being actually the first speaker of this seminar series. And I hope over the next 35 minutes or so, I'll be able to give you a high up level of PASC and some of the features of PASC, as well as actually what background materials may I have with regards to post-acute illness syndrome and persistence of symptoms in that, to see what's similar as well as what's different, because they have implications for how we want to be able to phenotype PASC, as well as actually management implications for how we can help these patients. So over the course of today's talk, I'm not going to talk about every possible symptoms of sequelae that has been described, of which there are many after the SARS-CoV-2 infections. I want to instead actually talk a bit about certain domains, pulmonary symptoms, fatigue and weakness, for example, psychiatric symptoms, and neurocognitive, both to actually kind of highlight how they may be similar, but also how they may be different in terms of their persistence, association of severity, predictors of outcome, and how they may be similar or different than what we have found in patients with, say, pneumonia, sepsis, ARDS, and acute respiratory failure. And what this might have in terms of implications for improving outcomes, both in terms of actually a need for phenotyping what PASC is. Right now, I actually consider it as a too big a garbage bucket of everything that happens after COVID. And in order for us to be able to get to understanding how to take care of these patients and improve their outcomes or prevent PASC, we need to have a better phenotyping as well as understanding how our COVID-19 treatment has impacted on these prolonged symptoms. And with that also, a touch base on some of my concerns with regards to health disparities in PASC. So let me start off with kind of an overview in the sense of, the impact of COVID-19. I was saying to actually Josh that it's a little bit distressing about how many waves we've had throughout the country in COVID. And while there's been a lot of attention at the fact that we've crossed 700,000 deaths due to COVID in the United States, it's important to remember actually the vast majority of patients with COVID survived. So actually the burden of survivorship, it's a much, much bigger issue than even actually how many patients we've lost. There are over 227 million survivors of COVID worldwide and over 42 million alone in the United States. So even if we're talking about something that affects 10% of COVID survivors, we're talking about a huge segment of the population. And we do see a high burden of symptom and disability on patients with COVID-19. So this is actually the Blue Coral study that was led by Terry Hoff and Jackie Washna as part of actually the clinical trials network that Josh was mentioning. I am a active participant in the NHLBI pedal network. And what we did was from the very beginning of the pandemic, develop a prospective observational cohort that now nears over 1,000 patients of hospitalized patients with COVID, with follow-up as well as imaging actually of these patients subsequent to their discharge to see what is the natural history and course of these patients. So this is actually an early look at 1 month after hospitalization. And at 1 month after discharge from the hospital, over half still reports new or worsening cardiopulmonary syndrome. And the symptoms are actually impactful in that 82% of these patients report that even a month out from their illness, they're not back to their pre-COVID-19 level of functions. And they have real world implications. Their illness resulted in significant financial stressors, with 23% of them saying that they have used up all of their savings because of their illness or because of the hospitalization. And almost 20% have either lost their jobs or needed to change their job in some way because of their illness or because of the COVID pandemic. And unfortunately, minority patients actually seem to be more burdened with these financial stressors than others. But, you know, we're hampered by the fact that right now the discussion in PASC is a lot of it is on reporting symptoms, and that we don't really have a valid definition for PASC that is based upon trajectories or outcomes or anything substantial. What we do have is some suggestions for definitions, such as the one put forth by the National Institute for Health and Care Excellence, which is define PASC as signs and symptoms that develop during or after an infection consistent with COVID-19 and continues for over 12 weeks. And that is not explained by alternative diagnosis. Now, the scope of symptoms and signs that has been reported after COVID is humongous, and it basically affects every possible organ system in the body. So I'm not necessarily going to talk about all of them because I think that those things might be better enabled by focused talks on just those organs. Rather, I want to actually focus on the most common ones, okay, that has been reported and how they may be similar or different from each other. Specifically, pulmonary symptoms, given actually when you have COVID-19, the vast majority of patients, especially when they're hospitalized, is basically COVID pneumonia. But also actually a large parts that deals with kind of systemic or neuro, such as fatigue and weakness, psychiatric symptoms like depression and anxiety, and concentration memory, or what is oftentimes called in the press as brain fog. The other thing I want to take note about is that this definition of PASC says it is not explained by alternative diagnosis, which brings into mind actually, in order for us to really understand what PASC is, you really kind of have to understand what is the sequelae from surviving pneumonia or ARDS or respiratory failure or sepsis, because in essence, many of the patients with COVID-19 had all those things. It's just that the etiology for the pneumonia, for the respiratory failure is COVID-19. So let's talk a little bit about some longitudinal studies looking at persistence of symptoms after pneumonia. And what we find actually is that even before the pandemic, pneumonia patients also have been known to have persistent systemic symptoms. That includes most commonly many of the things that we see in PASC: fatigue and weakness, okay, cough and shortness of breath, as well as confusion. Now, when they looked at see actually how long they persist, on average, it's about 3 weeks after hospitalization or after their diagnosis of pneumonia. But if you look at actually the interquartile range and the median, you see that actually 25% of these patients have symptom durations that's greater than 3 weeks. Now, how much longer, I don't know, because they didn't follow these patients much longer. But what's interesting is that they did see it, that the persistence of similar symptoms was similar for both older and younger patients. It didn't matter. And they did see the hospitalized patients do tend to have a longer duration of symptoms, especially with regards to, say, weakness and tiredness, but not as much so for things such as like shortness of breath, for example. Now, how does this differ from, say, PASC? So this is a study where we did a cross-sectional prevalence study calling patients up who have been previously diagnosed with COVID-19 within the Montefiore healthcare system. So this included both inpatients and outpatients, and we call patients up who were diagnosed a month ago, 3 months ago, and 6 months ago. And what we found was that uniformly across all of the different time points, about 25% of the patients reported persistent symptoms after recovering from COVID-19. Most common: fatigue, breathlessness, pain, anxiety, drowsiness. And except for a change in taste, which did get better over the course of the 6 months, the other symptoms only got slightly better. Fatigue, for example, went from 28% down to 22%, but it was still pretty prevalent even at the 6-month mark. Now, this is particularly concerning for us at Montefiore because we were at the blunt of the first wave with regards to COVID. In the first wave, a large number of the cases that were seen in New York State, and New York City accounted for the vast majority, over 80+% of those cases. And within New York City, the Bronx, where Montefiore was located, is actually one of the hardest hit boroughs within the United States. And this, as you can see, has continued. To address the needs of our patients who have survived COVID-19, Montefiore had created the COVID Recovery and Engagement Clinic, or the CORE Clinic, whose goal is to understand, evaluate, and manage patients with post-acute sequelae of COVID-19. And is meant to be a multidisciplinary clinic led by Dr. Marjan Islam and Dr. Seth Condon to both evaluate and manage the PASC symptoms of these patients, including pulmonary assessment and neurocognitive and psychiatric screening and further testing if needed, as well as determination of the social determinants of health evaluation and referral to a subset of people in different subspecialties depending on their symptoms, and direct links to physical and pulmonary rehabilitation. We have now in the clinic over 360 patients that are being evaluated and followed for symptoms that persist after the COVID infection. And in this clinic, what we find is a high burden of symptoms. 70 to 80% of the core patients report persistent symptoms. And this is after about 5 months after their initial illness. And they're not mild symptoms. Most actually rate their symptoms as moderate to severe. And it seems to impact their health status. 84% of the patients in core clinic report worse physical function, even 5 or 6 months out than compared to their pre-pandemic or pre-illness state. 57% reports worse cognitive status, and 68% reports a worse emotional status compared to a pre-illness basis. Dr. Islam has a grant from the American College of Chest Physicians to look at actually ultrasound findings in patients who are still complaining of pulmonary problems about 6 months out from their COVID infection. And what he finds is that a large number of these patients still have abnormal lung ultrasounds with things such as what you see here. These are B lines that affects sometimes one, sometimes multiple quadrants in their lungs. And the B lines are usually indicative of either some interstitial changes or some edema that persist. He also found actually that these abnormal lung ultrasound, when you score them in terms of severity, correlates with more desaturations when you have a patient do a 6-minute walk. And indeed, actually, these patients are still right now only able to accomplish about 52% of what is predicted for their age and status in terms of how distance walk within 6 minutes, indicating that there's still findings of significant pulmonary limitation. So how does that then depend and vary, or how compare with other etiologies? So we've actually have a long interest, as well as actually a volume of data looking at the longitudinal recovery patterns of patients with ARDS. And just to make the comparison equal, I'm comparing actually patients with COVID-19 that likely have ARDS because they were on high flow, non-invasive, invasive mechanical ventilation, to what we know on patients who don't have COVID and had ARDS from before the pandemic. And what you find is a few things. So in terms of actually spirometry, FEV1, FVC, most patients actually do not have lasting deficits with regards to their pulmonary function testing. Whereas 60 and at 12 months after the ARDS, the median is mostly within normal range, but you can see actually that it's still about 25% based upon the interquartile range of the patients may still have deficits in terms of FEV1 and FVC at about a year out. And what we see in ARDS is that that's it. They may get better for up to about a year, and then they don't get much better after that. They're stuck. In COVID-19, actually, we see similar numbers. About 13 to 14% of the patients still has decrease in terms of the FEV1 and FVC from predicted, and this decrease over the 12-month period of time. We don't have longer data to indicate what happens at that point, but if it's like ARDS, it's mostly actually a plateauing, but it's a minority. The most affected parameter with regards to lung function tends to be actually the diffusion capacity and the 6-minute walk, of which actually the patients with ARDS tends to about stabilize even at the mild abnormal ranges, 6 to 12 months out from the illness. And we see similar findings actually in the COVID-19, where a little more than half, okay, similar to what we have seen in the ARDS, are less than 80% predicted for the diffusion capacity. 6-minute walk, however, seems to be actually a little bit better with regards to COVID-19 patients. So in the ARDS patients, they are below what is predicted, and they're below even beyond a year out. But the median actually in the COVID-19 patient in this year-long cohort is a little bit closer to normal. Now, we do see in both ARDS as well as actually COVID-19 that severity matters. The more severe the disease, the greater the effect on lung function. When looked at DLCO, is a nice pattern of severity leading to more decrease in the DLCO. And in terms of abnormal CT, which actually mimics the data that we see with the ultrasound, you see it mostly actually in the patients with severe illnesses that requires high flow nasocannula and invasive mechanical ventilation. But you do see it in a large proportion of those who are less severely sick as well. Now, some people may be actually talking about the post-intensive care syndrome and how it may relate to COVID-19. You'll see that I actually don't talk about that an awful lot, partly because I don't know what ICU means much anymore. And that is because, before the pandemic, we used to think of the ICU as a place where patients with respiratory failure and septic shock or severe sepsis will end up going. But that is completely turned around during the pandemic. So this is actually from a paper that looked at multiple regions across the country. And just to give you an idea of what happened at Montefiore, this is the total number of ICU beds that we had. But this is red is the total number of COVID patients on ventilators. So the ICU designation as to critical illness completely falls apart in much of the country, especially during peak surges, where patients who are respiratory failure are actually commonly treated outside of the ICU. Vent occurs outside the ICU, and even actually patients who should be on the vent may not actually be put on the vent, partly because we're using a lot more high flow nasal cannula. And I can tell you that I'm part of another group that actually is working on redefining ARDS. Because actually most of us believe that our old definition that requires the ventilator or PEEP is probably outdated because of COVID, of how severe with respiratory failure we saw being managed outside the ICU using high flow nasal cannula as much as possible. Now, there are things that actually differs quite a bit with regards to COVID-19 than what I've reported with ARDS. And that is actually the persistence of symptoms, even the pulmonary symptoms, in patients who are not hospitalized. So here we looked at patients who are hospitalized or not hospitalized in a core clinic. And unlike other studies with sepsis and ARDS, we still see a high and similar burden of symptom on patients who are not hospitalized. But what we do see, and that has been reflected in other studies as well, hospitalization is associated with greater disability from the symptoms. And that's the other link. Symptoms in and of itself, it's only partially informative. We need to be able to link symptoms with function to understand the true impact. And whereas the symptoms may be similar between hospitalized and non-hospitalized patients, the degree of disability and impact on their function is very different. Now, the other most common problem that we see reported by patients with COVID-19 infection is fatigue. And fatigue is actually not a new thing with regards to viral syndromes. There have been actually other reports of post-infectious symptoms with a great deal of fatigue, such as myalgic encephalomyelitis, chronic fatigue syndrome that has been associated with different types of viral infections, such as Coxsackie, EBV, CMV, and other coronaviruses, such as MERS and even the SARS-CoV-1 from back a number of years ago. But all of these are actually still poorly characterized, poorly diagnosed with unclear implications for treatment as well as prognosis. But what is clear, however, is fatigue and weakness are among the most common and persistent symptoms reported by patients. Seen in actually about 50 to 74% of the patients who have had COVID-19 even 6 months out from their illness. Now, we do see that there are improvements. So whereas we see it is much more severe in terms of fatigue and weakness among those who are more severely sick, we do see actually they all decrease, although not completely eliminated by about 12 months time. We see similar findings in ARDS and in sepsis, even without ARDS. About 2/3 of patients with ARDS has continuing fatigue even 12 months out from their ARDS. And nearly half of those patients report both fatigue and impaired physical function because of the fatigue. Now, what's different with COVID-19 is that the fatigue may be worse in hospitalized patients and may also be much worse in patients who are more severe. but is also seen and common among non-hospitalized patients. So this is actually from a study that we did as part of the CDC IV network, and was among the first to actually report the persistence of symptoms in non-hospitalized COVID patients, where up to 38% of the patients 4 weeks out from their diagnosis of COVID-19 was still reporting fatigue. Now, you understand that nearly 100% of these patients reported fatigue as part of their acute illness. Okay, so that's almost uniformly a part of these patients' initial presenting symptoms. But over a third of them were still fatigued after about a week, about a month out. And other studies have found that up to 14% may still be complaining of fatigue at 6 months' time. I'm going to shift a little bit over to the neuropsychiatric sequelae. So there is a high prevalence of neuropsychiatric symptoms such as anxiety and depression after COVID-19. So many patients, over a third of these patients report these symptoms with their acute illness, but actually post-illness, 3 to 6 months out from their illness, 10 to 12% of the patients are still reporting symptoms of anxiety and depression. But it is important to remember, actually, that these psychiatric symptoms are not specific to patients who had COVID-19 during the pandemic. And in fact, when you look at actually a random sample of the US population in terms of survey for anxiety symptoms as well as depression symptoms, we find a high prevalence of depression and anxiety from the whole population during the pandemic. If you look at actually depressive symptoms, there's been more than a doubling in the prevalence of patients reporting moderate severe to severe depressive symptoms during the pandemic compared to before. Similarly, when you look at anxiety, in terms of generalized anxiety as well as social anxiety, that regardless of whether they had COVID or not, the population as a general had more anxiety with the pandemic than before the pandemic. And what's different than what we have seen with regards to other cases of post-acute illness psychiatric symptom is that it seems to worsen over time. So yes, there is more anxiety and depression among the more severely ill with COVID-19. And that does seem to decrease a bit from 6 months to 12 months. But if you look at the less severely ill patients, those not needing oxygen, those needing supplemental oxygen, those patients reporting depression or anxiety actually increased at 12 months compared to 6 months. And we see that also with ARDS. So when we looked at actually 1 year and 2 year outcomes with regards to reporting of anxiety or depression, we see that anxiety, it does, and anxiety correlates with severity of illness, just like we saw in the COVID-19. And they're the same, maybe go down a little bit from 1 year to 2 years, but depression actually worsened 2 years out from 1 year. Now, what are the predictors then for why some patients may have anxiety and depression? And again, they're very similar between the COVID-19 patients and those patients with respiratory failure. So again, severity, there seems to be a dose-dependent effect, even though it's not significant there. And similarly, we see the worse in terms of the PF ratio, the worse in terms of the duration of mechanical ventilation, the more likely they are to report continuing anxiety, which makes a certain amount of sense. Being in the ICU, being on ventilators, having a lot of tubes is extremely scary environment in spite of the best that we do on it. But also older age and women are huge predictors for continuing anxiety and depression among patients with COVID-19 and ARDS. But it turned out the largest predictor of psychiatric symptoms, such as anxiety in the COVID-19 era, is actually stressors related to COVID. And they're mostly social and economic stressors, such as, feeling alone, difficulty with family and relationship, difficulty with finances, holding a job, rent. And remember, we had just talked about actually the impact of COVID-19 on the financial toxicity of some of these patients. So, so in some ways, actually, this makes a certain amount of sense for why things may get worse. Because if these are actually the largest contributor to the psychiatric well-being of patients after COVID-19, these are things that actually may not get better even as the body heals. And if anything actually gets worse, because it's the longer you're sick and further out you are, it's harder and harder to be able to recoup the losses from some of this stressors. The neurocognitive, I'm going to shift to. So we have reported actually a high incidence of acute neurological symptoms and presentations with patients that were admitted for COVID-19. In fact, about 12% of the hospitalized patients with COVID-19 has some kind of an acute neurological symptoms requiring some imaging. And most commonly, it is altered mental status that could not be explained by other reasons. And we find actually that this persists. So in terms of actually symptoms of like impaired concentration, attention, or memory, yes, about a third of the patients have those during the acute illness. But even actually 3 to 6 months out, nearly 20% of those patients are still reporting problems with cognition. In our core clinic, which is admittedly a selective patient population, because these are patients who are seeking our clinic because of persistent symptoms, but 41% of these patients have significant cognitive impairment by the MoCA blind test 5 or 6 months out from their illness. And we see this also in patients with ARDS and other kind of conditions such as sepsis and acute respiratory failure. Nearly all of these patients with ARDS have cognitive deficit at the time of hospital discharge. And it does improve, but it's plateaus in terms of the improvement after about a year or so out. There isn't much more improvement after about a year. And longitudinal studies have found that we have similar findings in other ICU survivors, where cognitive impairment can range anywhere from like 20+% up to 70%, depending on the patient population and when you look at them. And longitudinal studies that have followed from these patients suggest that these deficits are both long-lasting, if not permanent, and associated with loss of jobs. Well, what about COVID-19? We're seeing actually a pattern that's very similar with what we're seeing with ARDS. The only difference is severity based upon actually how sick they were. In COVID-19, we see that their cognitive deficits after their acute illness is common and also dose-dependent with regards to severity, with the largest actually deficits seen in those patients who basically had ARDS. In fact, actually, the deficit that they're seeing among these patients is equivalent to the deficit you would expect from 10-year decline for patients that are about between the ages of 20 to 70. So these are not insignificant deficits that we're seeing. Now, one of the problems, however, is that many of these studies are not accounting for baseline cognition. Now, why is that important? It's important because we know from other studies in sepsis and ARDS that there are certain predictors of cognitive dysfunction. And that includes how sick they are at the time of their acute illness. So their degree of hypoxia and hypotension at the time of acute illness. Some iatrogenic injuries that may happen in the hospital system itself, such as excessive sedation and delirium, but also older age and pre-existing cognitive decline, predicts for greater decline after any kind of an acute insult. Now, that's particularly important in COVID-19 because we know, especially at the beginning of the pandemic, that older patients were disproportionately affected, and that frail patients, patients in a nursing home, patients with comorbid diseases such as diabetes or hypertension, which puts them at a higher risk for some cognitive deficits or cognitive lower cognitive reserve, were also more affected by COVID-19. So it's important to actually understand what their pre-illness status is to truly understand what the consequence of an acute injury from sepsis or COVID-19 is on cognitive trajectory. Now, this was done in sepsis. So this was another study that was like so smart from Jack in Washington, where he took a cohort of patients from the health and retirement study in which they have these baseline assessments yearly in terms of function and in terms of cognition. And he linked them to the Medicare claims to determine actually which of those patients had a hospitalization for severe sepsis. And then he looked to see what happened with regards to their functional testing as well as the cognitive testing before sepsis, and then what happens with regards to the trajectory after the hospitalization for sepsis. And this is what he found. So as expected, patients who had poor functional status, so more limitations in terms of the activities of daily living before sepsis, will have more limitations after sepsis, but they will have more compared to even their baseline. And what's frightening is actually even those who didn't have any limitation to begin with acquired new and lasting limitations in terms of their activity levels, even actually 5 years out after their septic episodes. And they saw a similar thing with cognition. When they looked at actually the prevalence of cognitive testing before sepsis and how many qualifies as moderate to severe cognitive improvement and mild, you see that there is a greater than nearly 3-fold increased risk of a cognitive impairment after a hospitalization for sepsis. And that is not the same effect that you see if they were hospitalized for a non-infectious etiology. The implication of this is actually quite staggering. And then throws COVID and how many patients were affected by COVID, it's even more staggering. And Jack actually mentioned this in terms of his discussion. Given published dementia and sepsis incidence rate for those aged 65 or older in the United States, the results suggest that nearly 20,000 new cases of moderate to severe cognitive impairment in the elderly may be attributable to sepsis. Now, wouldn't it be great if we could have a similar kind of a longitudinal studies with regards to COVID-19? And we're seeing some hints of that, okay? But you have to be a little bit careful about the cohorts that you have. So this was actually a study that looked at this longitudinal cohort of patients in Hypoxia that was tested regularly for cognitive impairment. They took a subset of this cohort that had normal pre-pandemic MRIs and EEGs and has at least 2 pre-pandemic MoCA tests so that it can see what the trajectory of decline may have been in these patients before the pandemic. They have to have no prior neurological problems such as seizures or strokes, and they specifically targeted non-hospitalized COVID patients and who didn't need oxygen, who didn't need corticosteroids, and didn't need hospitalization. So these were mild. Now, their diagnosis of COVID was based mostly on positive serology, okay? But what they did find is that the patients who had a positive serology had a significant decline and trajectory in terms of their MoCA testing after the pandemic compared to what they were doing before the pandemic. And if you define the cognitive decline as a 4-point greater difference than the expected decline that they would see based upon their pre-pandemic trajectory, there was nearly a tenfold increase risk of having cognitive decline in patients who tested positive for COVID-19. Okay. Now, the decline is still subtle enough that none of the patients or families reported any cognitive problems. And you need these levels of tests and systematic surveillance to be able to pick these out. But actually, 2 of these patients with cognitive decline actually has newly abnormal EEGs with temporal lobe slowing, although none of them have MRI. The potential implication of this, as you can imagine, is quite scary, given actually the number of patients who had COVID-19. And what this might mean for more severe patients is not yet known. So just to kind of summarize, we talked a little bit about the different domains of PASC and how they may be similar in the sense that they persist at 3 to 6 months, but also how they may differ. Like, for example, most of these symptoms do get better, but for whatever reason, the psychiatric symptoms get worse over time. Some of them are correlated with regards to severity of illness, such as the pulmonary symptoms, for example, and the neurocognitive. But some, yes, they're bad if they have ARDS, but if it's anything less than ARDS, it's not clear that there's a severity component. And the predictors for what drives actually a higher likelihood of, say, neurocognitive or the psychiatric symptoms are very different, with some social and environmental factors being more important for some of these domains. Understanding how these domains differ by these different characteristics is important because we shouldn't lump all of these together. And we're seeing actually that some of these domains share, and some of these patients share a similar prevalence, risk factor, and trajectory is what we're seeing in other post-acute illness such as ARDS and sepsis. That is not to say, however, I think that they are the same. I don't, because clearly what we're seeing with regards to COVID-19 is that there is persistence of these symptoms and dysfunction even among the mildly ill patients. And that is both staggering as well as different than anything that we've seen before. Which means actually that it's really important that we go and better phenotype PASC, and not just phenotype what has been done so far in terms of grouping people in terms of presenting symptoms, but we need to be able to phenotype PASC not only in terms of the symptoms they have, but in terms of the trajectories and outcomes. And it's likely that there's going to be some overlap between PASC and what we're seeing with other post-acute illness sequelae, and maybe actually patients who have ARDS or sepsis, of which many patients in the hospitals had with COVID. It may be very similar to what we have seen in the past with ARDS, but clearly, actually, the non-hospitalized COVID patients is going to be a different etiology and a different implications. But lumping all these symptoms and findings of PASC into one syndrome, I think it's just going to blur the different trajectories of recovery. It's going to blur the different impact on function, to blur different mechanisms, and hamper actually our ability to find potential symptoms. Because I think in likelihood, we may have the severe COVID infections, and that leads to a spectrum of different severity of organ failure. But in the end, actually, when we look at sequelae, we're going to find actually there are some patients with no sequelae after whatever time we defined it to be. Some that actually has persistent symptoms that may be related to the need for a prolonged recovery or impaired recovery, for all we know, to injury that was sustained during their acute illness, to the physical injury to their organs and organs during their acute illness. But there may also be patients who have symptoms and impairments that's related to psychosocial stressors or other non-illness specific, but environmental, economic, social implications of their illness. And then that is still yet to be finally kind of elucidated is whether or not there's persistent injury and dysregulation after the acute infection. And it's important partly because we do have some interventions that we know are beneficial. Like, for example, when you actually look at what has been found in sepsis, ARDS, pneumonias, and other acute injury, the most effective ways to limit these prolonged symptoms and dysfunction is to limit the initial injury itself. So lung protective ventilation, early mobilization, decreasing iatrogenic injury that occurs in the hospital, such as delirium, over sedation, and the use of benzodiazepine. Now, I have to tell you, during the pandemic and surge period, these were extremely challenging. And whereas we all know that these were important to do, I can tell you, between running out of medications to sedate patients, taking care of patients in non-conventional spaces in the hospital, and having a lack of staff means a lot of these were not done or done to the way that we like during the pandemic. And then there are others, right, that limits are aiming at not so much reversing the injury, but helping patients regain function or help them compensate for it, because it's actually not clear that some of these findings that we see, especially from, if we can extrapolate from, say, sepsis and ARDS, are necessarily reversible. And that includes physical and occupational therapy, cognitive therapy, as well as cognitive behavioral therapy, which we know has been helpful in these patients. What's less clear is whether or not other interventions like corticosteroids for, say, patients who may have evidence of cryptogenic organizing pneumonia after recovery, or antifibrotic agents work on these things. And these are being studied, and it's not even yet clear to me how much consistent inflammation or consistent injury is still happening. Now, what are the implications then? So I talk a bit about actually the importance of limiting the acute injury in order to be able to help with the long-term outcomes of these patients. So then how do the COVID-19 treatments that many of us, including I, have been very active in the past year and a half to try to improve the outcomes in COVID-19? So one is oxygen, and this is actually no small matter for a number of reasons, right? So whereas we, yes, do try to avoid hypoxia by giving oxygen, the reality is during the pandemic, many patients was probably more hypoxic than we would have allowed before the pandemic, whether it be because, as you've heard right now from certain states, they're running out of oxygen and reducing the threshold for which you would require oxygen from, say, somewhere in the mid-90s to, like, say, 90% O2 sat. And this is where, our hats off to Josh in having the foresight that in order for you to understand PASC, you really need to have high granularity data from during the hospitalization to understand the extent of the acute injury, even in they're not in the ICU, and how that might pertain to the persistence of symptoms afterwards. And this is particularly true, actually, because in addition to the fact that, some of these places may have been running out of oxygen, you also may have heard about this myth of happy hypoxia. And reality is that there are a number of patients, even those who are not critically ill, that was basically allowed to be left hypoxic because they thought that that's fine, that's happy hypoxia, which has significant implications, especially for neurocognitive outcomes, because that's one thing that has been found to be consistently predicts for cognitive decline. And in addition, Michael Sodringer, using the high granularity data from continuous O2 monitoring of patients from the electronic health record, shows that undetected hypoxemia, even in a monitor setting, is common because of actually the way O2 saturations in the pulse oximeters was tested and proved in the United States. And that the undetected hypoxemia may affect Black patients more so than in white patients. And what the implications might be of these undetected occult hypoxemia maybe a long-term outcome is unclear. Corticosteroids. So that's another one that we've been using to treat patients with acute COVID infections. But corticosteroids has also been known to result in weakness and fatigue in patients. And indeed, actually, you see here that inpatient or acute illness treatment with corticosteroids was actually significantly associated with reports of continuing fatigue and muscle weakness even 1 year out from their illness. Now, from the active platforms, we have anticoagulation, monoclonal antibodies, and remdesivir. And right now, we do not have any data on understanding how these regimens and these treatments may or may not influence the persistence of symptoms in patients with COVID-19. And then last few minutes, I'm going to stop very quickly, is the gender and racial disparities. So we know they exist in acute COVID-19, but we're beginning to see that there may be some disparities in PASC. Certainly female gender seems to be in multiple reports have a higher incidence of complaints about persistent symptoms. But there's been mixed data about minorities. In Blue Coral, they were less likely to report symptoms, but in this other longitudinal studies, they were more likely to. We have no current data on disparities in access to these post-COVID clinics like the core clinic that we have in Montefiore. But we do have evidence that even before COVID, there has been racial and socioeconomic disparities in access and quality of the post-acute illness care. Blacks and patients with Medicaid are much less likely to be transferred to a long-term acute care hospitals after an ICU stay, and much more likely to be sent home with no services. And even if they get sent to a long-term acute care hospitals, they seem to go to facilities in which they may not have as much services. So they have actually less improvement in terms of the activities of daily living compared to actually non-minorities who were discharged to acute care hospitals. So to the end, we do need to better phenotype PASC and the different domains, and both in terms of the trajectory, their outcomes, and the prevalence. And we need to actually understand better the overlap between PASC and other post-acute sequelae, because the implication for what we have known already can work or not work, can have implications about how we can help patients with PASC now. And of course, there needs to be more work looking at racial and gender disparities. So I'll stop there. I think I ran a little longer than I had intended, but I'm happy to take questions.
Thank you so much, Dr. Gong. There's a ton to talk about, and I know we're right at the top of the hour, and I'm sure people are going to have to be hopping off. So first, let me say thank you so much for really kind of helping us get our brains around this incredibly complex set of issues that we're, as you say, there's going to be a lot of need. There already is a lot of need, and it's likely to be with us for a while. I will end us with just one quick comment question from Tim Buckman that came in just a little bit ago. He said, as you in the midst of your presentation, he said, the impact of these findings cannot be ignored. One of the great challenges with COVID is that the illness itself is dynamic. The phenotypes of the patients and their acute symptoms has changed. Is there yet any sense that these longer outcomes are similarly changing? Or alternatively, is there a sense that these long-term findings will be sort of a convergent trajectory for all survivors, regardless of whether they survived in March 2020, March 2021, or later, even September 21? Obviously, we're still learning about the later ones.
So that's a fantastic question. And the fact is that we don't know, because as you can imagine, the later patients are not going to have as much of a follow-up as the earlier patients. But there are some suggestions that this is likely going to change. So for example, a lot of the domains that I've talked about in terms of the persistence of symptoms is actually related to some degree to what is happening during their acute illness, right? And I've mentioned actually some of the indications during their acute illness and their exposure to like hypoxia, hypotension, or whatever it is that may matter. And what we seem to be seeing is that with the Delta variant, for example, that there are suggestions that these patients who are being hospitalized with Delta, they are younger, but we're not seeing a big difference right now with regards to younger age and the persistence of these symptoms. But they also may be more severe, which means actually that they may have greater implications for more prolonged symptoms afterwards. But we don't know. That's all speculations right now. And a part of what's really needed, okay, is less of these cross-sectional surveys and more longitudinal analysis of these patients as they're coming in at a different time point with different variants and how long it lasts and how their symptoms change.
Excellent. Well, I know we are over time. We could talk about this for another whole hour, and we'll be talking about this for quite some time. So, Joe, I don't know if you have anything to take care of here to conclude, but otherwise I want to thank you again, Dr. Gong, and thank all of our attendees and panelists for being here, and we'll do this again soon.
Well, if anyone has any questions that we didn't get to, please send them to me, and I'll make sure that Josh and Dr. Gong get them, and we can begin to answer some of these. But I think this is a great first seminar. Give us a broad overview, and really, I think what's most important to me is the context in which this sits with respect to other therapeutic or diseases, and I think that's where it becomes a really important thing to understand. So thank you so much, and I wish everyone a great day, and I just think this was a great start. So thank you, Dr. Gong.
Thank you for the invitation. Enjoy your day, everyone.
Thanks, everyone.
Thank you.
Stay safe.
Bye-bye.
Thanks so much, Dr. Gong. Thank you.